rounds, and it's lovely to be here today, and it's a beautiful spring day. And I just also want to acknowledge that we are now into the third round of lockdowns, and just hope that everyone's keeping well and safe. I'm so pleased, Maria, to have Dr. Maria Velez, clinician-scientist and associate professor here today from the Department of Obstetrics and Gynecology and adjunct scientist at the Institute for Clinical and Evaluative Sciences. She's here presenting her work exploring reproductive health needs of female adolescents and young adults with cancer. And I just want to let everyone know, because there's a number of people I think that are over at the COVID seminar, we'll be audio recording these, and they'll be posted on our website afterwards for sharing. So Maria, I'm going to hand that over to you, and thank you so much again for presenting here today.
So thank you, Catherine, for the introduction, and thank you also for the invitation to present my work at these rounds, which is great. So as you mentioned, I am an associate professor in the Department of Obstetrics and Gynecology, and I also share a cross appointment with the Department of Public Health Science. And today I'm going to talk about the reproductive healthcare needs of female adolescents and young adults with cancer. I don't have any relationship with commercial interests or potential conflicts of interest. So we know that cancer therapies have resulted in dramatic increases in survival, and we are grateful with our oncologist colleagues who are working with our cancer patients. We also know that it's essential to optimize health and quality of life among survivors. And many cancer therapies, unfortunately, they have adverse effects in the ovaries in women, and then can cause increased risk of infertility and also premature ovarian insufficiency, also known as POI. There is a particular group which are called adolescents and young adults, AYA. These patients are from ages 15 to 39, and they are a unique population in the way they experience their cancer journey. This age range includes the majority of the reproductive life span, where fundamental events in this woman's life occur. Previous population-based studies have investigated childbirth rates in cancer survivors. These are studies from Norway, Finland, and Canada, including patients, like 300 patients to 2,000 patients who have experienced cancer. And they show, as measured by childbirth rates, or like the number of births that they have, that these cancers will have an impact in lower fertility rates. What are we doing here at Queen's? So in our department, we have this reproductive and perinatal research unit, and have been working to investigate what is the effect of infertility in female adolescents and young adults with cancer. We recently published our results that I did in collaboration with ICS scientists. Mike Green has been mentoring me, and I have been also working with Harriet Richardson from the Department of Public Health Science. So the objective of this study is to assess the risk of infertility diagnosis after cancer in adolescents and young adults. This study was conducted at ICS Queens. We have an excellent team here, and is a population-based matched cohort using universal healthcare databases in the province of Ontario. We selected an exposed group of women who had cancer at ages 15 to 39 between 1992 and 2011. We selected brain, breast, colorectal, hematological, thyroid cancer, and melanoma because these are in the top 80% most common cancers in this age range that are not gynecological cancers. We also selected women who were at least 5 years recurrence free. And we excluded women who had a previous infertility diagnosis or who had tubal ligation, hysterectomy, or oophorectomy. We selected a control group of unexposed women, women who did not have cancer, and we matched these women, 5 unexposed women per each cancer patient. And we matched this based on age and census subdivision. We followed these subjects in the cohort until December 31st, 2016. Our outcome was an infertility diagnosis after 1 year of cancer, and we identified this using OHIP billing codes. The billing code for infertility is the ICD-9 code 628. Sorry. So in the results, we were able to identify 14,000 cancer survivors and over 60,000 unexposed women. The age between both groups was similar, 31.4 in cancer survivors compared to 31.2 in unexposed women, and the median follow-up time was 14 years. Infertility diagnosis was more common in cancer survivors. Overall, it was 12% compared to 9.2% in unexposed women. The age of infertility diagnosis was similar between both groups, 34.5 years in cancer survivors and 34.9 in unexposed group. We had over 5,000 women with thyroid cancer, 3,700 breast cancer, over 2,000 women with melanoma, over 1,000 Hodgkin lymphoma, and the rest were less than 1,000. And they included women with non-Hodgkin, brain, colorectal, and leukemia. This is the proportion of infertility diagnosis among exposed and unexposed. We saw that women with breast cancer, leukemia, Hodgkin lymphoma, non-Hodgkin lymphoma had a higher prevalence of infertility, but we also noticed that women with thyroid cancer and melanoma had a higher proportion of infertility diagnosis compared to unexposed women. In the adjusted model, we conducted modified Poisson regression and we adjusted by income quantile. And we documented that women with leukemia had the highest relative risk at 1.56, followed by women with Hodgkin lymphoma, breast cancer, non-Hodgkin lymphoma. Again, thyroid cancer, we also noticed the association, and also a low but significant association for women with melanoma. We then stratified our results according to parity, and we noticed that in nulliparous women, all the association remained. However, in parous women, only women with thyroid cancer continued having a positive association with subsequent infertility diagnosis. So our interpretation is that the female, adolescent, and young adults survivors of breast cancer, hematologic cancer, thyroid cancer, and melanoma have a higher risk of subsequent infertility diagnosis compared to age-matched cohort controls. We also noticed that parity previous to cancer diagnosis modified that effect, and it seems that nulliparous women are more likely to be diagnosed with a subsequent infertility diagnosis, or at least more likely to seek infertility treatment compared to parous women. We acknowledge limitations as, for example, that the validation of the ICD-9 code has not been performed. However, we did multiple sensitivity analysis comparing not only one ICD-9 code, but using 2 codes, or restricting only to those patients who were seen by fertility specialists, and our results remained the same. We also acknowledge that there are non-biological factors that influence the likelihood of seeking infertility treatment, and these might not be captured in administrative data sets. So we conclude that reproductive health surveillance in female AYAs with cancer is a priority, especially in those with breast cancer, leukemia, and lymphoma. Our finding of a potential effect of thyroid cancer, we know this is subject to overdiagnosis, and to a lesser extent, melanoma need to be further studied. We also know that additional factors, for example, the type of cancer treatment, needs to be assessed in future studies. And that's how this program started. So we wanted to go further and investigate what is the effect of cancer treatment. And for this, I have had the opportunity to mentor or supervise students with the Department of Public Health Science. And my first student was Harris. Harris completed his master's in epidemiology last year. I co-supervised him with Dr. Harriet Richardson. And now Harris is working as a data analyst at ICS in Ottawa. So Harris wanted to study what was the effect of thyroid cancer treatment in subsequent infertility diagnosis. Thyroid cancer represents almost 6% of all cancers in women in Canada. And this is the cancer that has most rapidly increased in incidence since 1992 to 2013. Here in Canada, in the AYA group, 15 to 39 years, thyroid cancer occupies the first place. We know that normal thyroid function is important to maintain normal reproduction. And there have been limited studies before that suggest that there is little or no adverse effect of thyroid cancer treatment on gonadal function as measured by serum gonadotrophins or sex steroids, and also fertility rates, which are the live birth rates that I mentioned before in patients with thyroid cancer treatment. However, there are not population-based studies, and that's why we did our study. We used the Ontario Cancer Registry, selected women 15 to 39 years who had thyroid cancer between 1992 and 2011. They had at least 5 years recurrence-free, and we excluded women with previous infertility diagnosis, tubal ligation, hysterectomy, or oophorectomy. We were able to identify almost 5,000 women and followed these subjects in the cohort until December 31st, 2016. The type of cancer treatments were less than total thyroidectomy, LTT, this is the reference group. Also total thyroidectomy or total and radioactive iodine. Again, infertility diagnosis after 1 year of cancer was identified using the OHIP billing code 628. Harris did modified Poisson regression models and adjusted by sociodemographic factors, including age, parity, area of residence, which is census subdivision, immigration status, income quantile, and the decade of cancer diagnosis. The mean age of cancer diagnosis was 31 years. The median follow-up time was 10.78 years. Infertility diagnosis was present in 11% of these women, and the age of infertility diagnosis was 35.3 in mean. In the multivariable analysis, you can see that relative to women with less than total thyroidectomy, those women who have total thyroidectomy did not have an increased risk of subsequent infertility diagnosis, and those who had total thyroidectomy and also radioactive iodine therapy did not have an increased risk of subsequent infertility diagnosis. So our conclusion is that thyroid cancer treatment total plus RI compared to LTT does not appear to increase the risk of subsequent infertility diagnosis. There might be additional factors not captured in this analysis, for example, the adherence to thyroid hormone supplementation that might play a role in our previous finding of a higher risk of infertility diagnosis in female adolescents and young adults with thyroid cancer. Our next results are now being conducted by Dr. Moira Rushton-Maurovac. Moira, she's a medical oncologist in Ottawa, and now she's doing her MPH in Berkeley. And I'm lucky to be her supervisor, and I am co-supervising her with Dr. Harriet Richardson. Moira is interested in the reproductive outcomes of young women with breast cancer, and she did this population-based study. She wanted to examine the effect of cancer treatment on infertility, pregnancy rates, and also premature ovarian insufficiency. So she selected women 15 to 39 years who had early cancer diagnosis, breast cancer stage 1 to 3, from 1995 to 2014. And we categorize these breast cancer patients according to whether they had received chemotherapy or not. The cases were matched with 5 non-cancer controls according to the year of birth and census subdivision. And the outcomes, as I mentioned, were infertility using OHIP billing codes, pregnancy as recorded in the mom baby dataset, and premature ovarian insufficiency defined as a diagnosis of menopause prior to the age of 40 years. These are the baseline characteristics. The groups were very similar except for parity. The women who did not have chemotherapy had the higher prevalence of nulliparity, while those who had chemotherapy were more parous. The other are similar. We were able to identify almost 4,000 cases of breast cancer and compare those to almost 20,000 patients with no cancer. The median age at breast surgery was 36 years. And these are the rates of the outcomes. You can see in blue women who did not have chemotherapy, but they had breast cancer. In yellow, those who had chemotherapy, and in green, we have the controls. Infertility women, even if they did not have chemotherapy, they had a 12% prevalence of subsequent infertility diagnosis. And those who had chemotherapy had 9% compared to 7% in women who did not have cancer. Pregnancy rates were significantly lower in the group that had chemotherapy. Premature ovarian menopause was also higher in patients who had chemotherapy. In the multivariable analysis, here we have the relative risk, and we can see that women who had chemotherapy had a higher risk of infertility with a relative risk of 1.81. Pregnancy rates were decreased in these women with a relative risk lower than 1, and premature menopause was higher in these women. But we also noticed that women who did not have chemotherapy also had a higher risk of a subsequent infertility diagnosis, 1.80, and also premature menopause. So our results suggest that all young breast cancer survivors face an increased risk of infertility and premature menopause compared to non-cancer patients independently of chemotherapy. And breast cancer survivors treated with chemotherapy have significantly lower chance of pregnancy compared to non-cancer patients. Our results emphasize the importance of pre-treatment fertility counseling for young women diagnosed with breast cancer. And In relation to that, I wanted to show the testimony of a patient who had Hodgkin lymphoma when she was 21. She says, I was strong when I was faced with the diagnosis of cancer, treatment failures, life-threatening infection, and being near death. But the pain that I felt when I heard that my life-saving cancer treatment would leave me infertile is impossible to describe. In that line, I had the opportunity to work with one of our residents in obstetrics and gynecology. She already graduated from our program, but she completed a master in public health at Johns Hopkins, and I was her supervisor for her project. She wanted to investigate the patterns of referral for fertility preservation in adolescents and young adults with breast cancer. She published her work already, and knowing that fertility potential has a major impact on the quality of life of adolescents and young adult cancer survivors, there is a new domain that is called oncofertility, and oncofertility has the purpose of conduct studies to improve fertility and fertility preservation in women with cancer. And unfortunately, the referral rates for fertility preservation continue to be low. We recognize that infertility may be a secondary concern during the period of active treatment, but it has a significant impact on the quality of life of cancer survivors. In a survey conducted in Canada, female patients between 15 to 45 years, they rate the impact of cancer treatment on fertility outcomes to be very important for them. And those who experience infertility as a result of treatment have depression, grief, and sexual dysfunction. So we selected women 15 to 39 years who had a new diagnosis of breast cancer from 2000 and 2017 using the Ontario Cancer Registry. We excluded women who had a prior dual ligation or who were not eligible by OHIP or who had prior infertility or a different cancer diagnosis. How did we define a fertility preservation referral? So we selected women whom between the breast cancer diagnosis and before the initiation of chemotherapy had a consult billed as an infertility diagnosis with the code 628. We identified 178 women who had a consult billed as an infertility diagnosis, and this resulted in a 4% referral rate. In the multivariable analysis, we noticed that older women, 30 to 39, had a lower chance to be referred, or women who had previous pregnancies. Also relative to the GTA, those women in the North Territories who had cancer had lower chances to be referred for infertility consult. Fortunately, we are seeing that in more recent years, the rates have increased, and also women who live in Southeast, and I can read that, Southwestern, so as have higher referrals to fertility consults compared to the GTA area. In terms of who are the physicians who are referring these patients. So in those who were referred, we noticed that the physicians were younger than 45, at least 52.8%. Also female physicians, 59% were female, and general surgery are the ones who are referring more frequently these patients. We also compare our rates according to some initiatives that have been put in place to increase awareness about fertility preservation, and have noticed that those initiatives have helped, and also that in 2013, when the removal of the experimental label from oocyte cryopreservation was removed, we also noticed a significant increase. Since 2015, the Ontario Fertility Program is in place, and it includes covering fertility preservation for these women. We will need to do further analysis to evaluate the impact of this fertility program. Another student is Charlie. She's a medical student finishing. She will know next week where she's going to do her residency. She was also interested in studying the fertility consultation in patients with lymphoma. The findings were similar. What is important here is that women who live in more areas with more deprivation, they have a lower probability of being referred. Also, parous women. Those who had more time from diagnosis to chemotherapy have a higher odds ratio to be referred, and also those women who have been diagnosed in more recent years, which is good. So fertility preservation referral rates remain low, and they continue to be influenced by patient demographics and also prognosis of the patient. And our findings highlight the need for further interdisciplinary coordination to address fertility concern in adolescent and young adults with breast cancer and hematologic cancer. So what are our ongoing studies? Satya is a second-year master's student in epidemiology. I'm co-supervising her with Harriet too, and she's interested in the reproductive factors that may act in relation to melanoma and infertility. She defended her protocol, so the results, hopefully the analysis will start in the following months. Susan is our PGY3 resident in obstetrics and gynecology, and Susan will be studying the effect of hematologic treatment, the treatment for hematologic cancer. We were also funded for the CIHR, Institute of Gender and Health. They created this program, Women's Health Clinical Mentorship Grant, and Amanda Belarjon is one of our PGY2 residents. We received this grant, and we are going to be studying menopause in young women with cancer. So for this study, we are working with Cancer Care Ontario, which is now part of Ontario Health. They are going to be sending next week this by mail information to about 6,000 women in Ontario who have been diagnosed with breast cancer and hematologic cancer. This is the envelope, how it looks. And I put here some of the questions that they are going to, if those who agree to participate are going to complete this survey. In the survey, we are going to ask information about the changes that they might have experienced after cancer diagnosis in relation to relationships with a spouse, partner, boyfriend, girlfriend, dating, plans of getting married, sexual function, and plans for having children. Examples of questions are, we are going to ask about the experience of infertility or difficulty getting pregnant after cancer diagnosis. We are going to ask if they have been referred to an infertility specialist. Also, if they received information about the impact that some treatments for cancer may have on fertility. Also, if they received information about options for fertility preservation, and if they made arrangement for fertility preservation. Finally, we are going to ask them, the survey is longer than this, but I just put some of the questions for your information. But in the end, we are going to ask them if they are interested in a follow-up, long-term follow-up study. And maybe we will be able to have a prospective cohort. This survey is going to be also linked to ICS. We are working with the ICS team, and we are going to be able to have more information specific to treatment that they received, blood work results, other information that we will be able to obtain through ICS. So this is the program that I wanted to present today. For those of you who speak French, you know that on means we in French too. So this is on care, but it's also that we care, and we care for the reproductive care of women with cancer. I want to acknowledge and thank to the amazing team that is behind this and my students. Also the Queen's Faculty of Health Science for Startup Funding, the Department of Obstetrics and Gynecology, and specifically Jessica Padol, our research facilitator. Also CIHR that has now funded the mentorship grant in ICS. I started working with Catherine, now I have been working with Shad, Shelly has also helped us a lot, and as I mentioned, Mike Green mentored me on how to conduct these ICS studies. I am also grateful to Harriet Richardson in the Department of Public Health Science for co-supervising the study, the students with me. And thank you all for being here today. We know it's the spring break and there is a lot going on with COVID. So I hope everybody stay well and safe, and I welcome questions if there are.
I just want to say thank you so much, Maria. You know, to hear the progression of your work is really quite remarkable and impressive. This isn't my area at all, but to be able to witness, you know, one study leading to the other, and all of the different students involved as well, and mentorship really is an exemplary program. So I just want to say thank you for sharing that. You know, I would love to share this to other grad students, just in terms of people thinking about, you know, how their work builds on each other. So I'm going to leave it open up for questions here. I see Joan and Kim have put themselves here. I'm imagining they might have a question or two.
I just have a comment. Great job, Maria. And it's so nice. I think ICES sometimes is an untapped wealth of knowledge, and it's really nice to see the work you've done. And I think, you know, having students involved is just amazing to keep the work going. So thank you very much for your presentation. It was very interesting.
Oh, thank you so much. Thank you.
Catherine, I think Trish had a question.
Oh, sorry, Trish. Please go ahead.
At least she had her hand up.
But I actually had a few questions. I was jotting down a few things to myself, Maria, as you were speaking, and I was really struck by the low referrals to infertility consultations. 178, that really struck me. And you know, considering particularly there was the Ontario Fertility Program, and just your thoughts or reflections on that.
Yeah, so thank you, Catherine. So we know that this is not the perfect way to know if the patients were referred or not. So maybe many of these women were referred, but they did not think it was necessary or was not their priority. And we are not able to identify this in ICS. That's why we are also hoping to, or we are doing this survey component to try to identify those women who, yes, they were informed, but they did not pursue that consult. So I think that that's why it's important to also do the survey component. And the survey will help us also try to validate if the codes that we are using and what we have used as the surrogate for fertility preservation referral what is the validity of that?
And I really like how you've added the different methodologies as well, thinking about like long-term that this could be a cohort that you study prospectively. But I really like the idea. What really struck me was the quote that you put up about the impact of infertility. You know, I think, you know, it's easy to see the numbers and see the impact, but to hear those personal stories. Do you have any open-ended questions in your survey?
We have is when we sometimes say like other, and that's an open question, but yes, that's kind of the questions that we have some open questions when the response doesn't fit in the options that we give, we say other, and they are open to provide the input. Yes. I think Joanne has I'm so sorry about that.
No, it's okay. Maria, I echo everyone's praise of your program. It's just, to me, it's reinforcing of that logical building, and engaging the students and the different approaches. And I had no idea you were, okay, let me back up. How did you get ethical and approval to approach 4,000 women that have had a cancer diagnosis? Who is releasing their names and addresses?
So Cancer Care Ontario, which is now part of Ontario Health,
Yeah,
they have this like amazing research team, and they have conducted multiple studies. We are not the first ones. Also, I didn't know. I approached them, and they say, yes, we do this. We can contact the patients. What they do is that they contact the patients, and they will mail. They will send by mail
exactly.
their introduction letter and our consent form, and like we describe how is our study and the consent form, and that's when we are able to contact them. So only those who accept to participate are the ones that we are contacting, like they will follow the link. But we are able to know those who don't accept to participate. At least we don't know the name, but we can link that to ICS, because we are working with you.
So
we know the characteristics of those who agree or not. But yeah, let's see how it goes. This is kind of like next week, or if not this week, but they were just waiting for final details to send the survey, and hopefully we are
interesting.
Yeah.
Good luck.
Thank you.
It's great work.
We're doing a similar trial. Hi, Maria, fantastic presentation, and thanks for your kind words. We're doing a trial where we're going to be doing something similar, but reaching out to a number of cancer registries, provincial cancer registries, that will similarly do mail outs for you, you know, at a modest $5,000 a mail out or something like that. But it does seem to be an option, but you have to budget for it.
Interesting.
Yeah.
It does allow you to access different types of data and bring in new information. I can see how impressive that is.
Well, it allows you to merge the self-report data about how they're actually feeling and experiencing, and all that stuff we don't have in the health admin data.
Yeah, and some of the quality of life data that you wouldn't necessarily have other than maybe ESAS, you know, data perhaps.
Oh, Elliot, couldn't we get all the primary care addresses? People who are in primary care.
I'm not so sure that's feasible, Joan.
I know.
But it does make you think about how you might tap into that in different populations.
Yeah.
I can almost see Joan's brain working.
No.
You can't do mail outs to SIPSN yet. You can't mail out to, no, through SIPSN.
I also had some thoughts too. I was writing notes as you speak, as I was mentioned, Maria, but the socioeconomic factors, you know, particularly played a role when you showed in terms of referral for consultations. And I know you put that in your models. How does that play out, the socioeconomic factors in infertility? Does that come out? Like, I know you didn't report it specifically, but it was factors. Does that influence infertility?
So, like biologically, yes. So, if, for example, like lower socioeconomic status is associated with it, like, for example, obesity, diabetes, uncontrolled hypertension, also STIs that can have an impact on fertility and infertility. And for fertility preservation referrals, as I show, unfortunately, yes, these patients seems that they are the ones that are less referred or consult less before chemotherapy. Now, fortunately, the fertility program, like Ontario Fertility Program, that was put in place in 2015, is covering fertility preservation treatment. So maybe after 2015, we are going to see an increase in women from lower socioeconomic quantiles. And the medications are still not covered and they are expensive, but there are organizations that can help with that. Yes. And
I don't know if other people have any comments or questions for Maria.
So I'm happy to see in the audience some of the and other students that I am supervising. So Bilan, for example, she's there, and Bilan is one of the MasterCard students in your school, Catherine, no, in the rehab school. And Bilan, she's interested, like in Ethiopia, when we think that maybe the interest in lower income countries is to study fertility rates and adolescents pregnancy. Bilan wanted to do different, and she wanted to evaluate the impact of infertility in disability, as a disability in women from Ethiopia. And so she's working on that now, which is great.
And, you know, it's so nice to see Belen here because she's from the School of Rehab, and I taught Belen in her first research master's class. So it was so lovely to see Belen. And I'm just curious because your work, Maria, is looking at population health data, and just a nod to thinking about Ethiopia and other contexts, sort of the methodologies that you might be using and that she is using. Because
yes.
What is the data sources in Ethiopia? And Belen, maybe you can even answer this as well.
So Bilan is using the Demographic Health Survey, DHS.
Okay.
As you know, DHS is used in multiple countries, and they have information about fertility. They ask questions about like how long have you been married, and if they have had a pregnancy or not. So questions that we can construct an infertility outcome, and they have been used for that. So that's what Bilan is using for the population-based component of her thesis, but she will be also doing qualitative research for the other two studies.
Yeah, and I can see the nice link between the qualitative piece, even just hearing your one statement from the woman who presented the impact. Yeah, and that would be a really nice combination study.
Yeah. Yes, and I also think that in my future studies or application, I also need to include like patient-oriented research and include patients and their lived experience.
That's excellent. Yeah. And I also just put a link to your, sorry, Joan, I just put a link to your blog for people to take a look because you've done a lovely job of presenting your work in your blog as well.
Oh. Thank you so much. Thank
That's
you.
good. To be a blogger is good. Have you thought about looking at pregnancy loss in relation to cancer and cancer treatment? Whether it's miscarriages or...
So in the survey, we are asking about pregnancies and what was the outcome of each pregnancy. Yeah. We have miscarriage, we have ectopic, we have stillbirth, and we have that information in the survey. With ICS, we can also do that. it might, yeah, we have to do some linkage and codes, and it's not always, we are not always able to identify those who don't consult. But yes, I think linking both the survey and ICS can help with that.
Yeah, because a referral for infertility treatment, as you identified, is like the billing code is probably not capturing all the cases, right?
Mm-hmm.
So you're under, but certainly there's probably, well, I know there is more opportunity to capture early pregnancy loss, and it may be, you know, may be interesting to look at the impact of cancer treatment on that.
Yeah, we can do that.
You can do that. You keep at it.
And maybe we are also another student that is here with us. She's a future student, and we are looking maybe in studying like pregnancy outcomes. So we are going to definitely doing that, pregnancy outcome. So that's another proposal that we will put in place.
Interesting.
Maria, one question that came to mind from my perspective, I know I worked with you with Chiefs of Ontario and looking at some Indigenous health issues around diabetes. And maybe I missed it in your presentation, but was there any thought given to looking at Indigenous health within this? I know there's a lot of administrative burden in getting a lot of the ethics approvals and getting Indigenous.
Yeah, I think that, thank you, Elliot, for that. I have considered that, and I think it's important to apply for a grant for that, because sadly, as a clinician, like here at KGH and seeing infertility patients, I can see how difficult it is for First Nations to have a consultation with us. And they have to fly here, then do all the investigations. And then when I say we need IUI, like intrauterine insemination, they have to be in Kingston for several weeks doing that. Or do you need IVF? Most of them can't afford those treatments or the medications. And it's also the logistics for them to organize that. So yes, that's something that is in my mind for future research proposals, but it's definitely very important.
Thanks, Maria.
Thank you.
Thank you.
I'm looking at the time here. It's 10:02, and I'm just thinking trying to give everyone a few minutes before they probably get to their next Zoom meeting. Maria, I just want to say thank you. Really impressive and really nice to see such a cohesive program of research here, and just the different methodologies I can see that you're bringing in as you move along as well. So thank you on behalf of HSPRI, and hope everyone has a lovely rest of the day.
Thank you so much for the invitation and for the attention, everybody.
Thank you,
Thanks, Maria.
Bye. Have a good week. Bye.